Good afternoon ورمضان كريم عليكم إن شاء الله أنتم وعوائلكم وأتمنى لكم النجاح والتوفيق. Today we'll have one of the important topics in medicine, which is pneumonia. You have tackled with pneumonia in different subjects before, but today we are going to talk about pneumonia from medical medicine point of view. We are going to define what is pneumonia, clinically of course, and we'll speak about epidemiology, classification of pneumonia. There are different classifications for pneumonia, clinical and radiological features, which is very important. The basic diagnosis of pneumonia depends on the clinical picture and radiological picture. Then the markers of severity, when we have to designate that this pneumonia is severe one, and then we'll talk about management of pneumonia. Pneumonia, what is pneumonia? The definition of it is acute respiratory illness, we know that. It is characterized by radiological pulmonary shadowing. So it is shadowing, pulmonary shadowing. You take X-ray and you see shadowing. This is pneumonia. This could be part of a lobe, could be lobe, could be multilobal. And in other words, it could be diffuse or patchy. And we will talk about them gradually. It's inflammation. Where the inflammation? Where occurs the inflammation? In the lung parenchyma. That is to say, basically in the alveoli and terminal bronchioles. This is where the inflammation occurs. Classification of pneumonia, there are different classifications. The one that we depend on it in hospitals divide the pneumonia according to the organism, the causing organism, into community-acquired pneumonia, CAP, hospital-acquired pneumonia, HAP, and pneumonia in immunocompromised. The three categories of pneumonia we are going to describe during this lecture. The context, the type of pneumonia that I have mentioned, it can tell you the microorganism which is predominantly cause that type of pneumonia. And we will see that in a moment. Lobar pneumonia, it means radiologically and pathologically, of course, it is confined to a lobe, at the boundary of the lobe. You know, the right lung has 3 lobes, the left lung has 2 lobes, as you know. So you will find homogeneous consolidation. And the word consolidation, it goes with pneumonia. And I will tell you in a moment what is the meaning of consolidation from pathological point of view. It could be to 1 lobe, more lobes, and usually associated with the pleural effusion when it is lobar. And it is called parapneumonic effusion. There is a word called bronchopneumonia. It's patchy. Hon. It's not confined to a lobe. Patchy alveolar consolidation associated with bronchial and bronchiolar inflammation, usually affecting the lower lobes. Usually seen in the lower lobes. Bronchopneumonia, and also we'll talk in some details about the bronchopneumonia. This table shows you the difference between lobar pneumonia and bronchopneumonia. which is quite important, just to understand what are the differences between them. Regarding the age, middle age, extreme of age. It means in too young, too old. Affect primarily health individual before pneumonia, while in bronchopneumonia, secondary to certain diseases which are already present in the patient, like COPD, low immunity, asthma, etc. Right? Regarding the gender, more males affected by Lobar pneumonia than female, while in bronchopneumonia equal. Look to the organism. In Lobar pneumonia, 95% of the cases are caused by Streptococcus pneumoniae, which is very important. Once you see Lobar pneumonia, you can expect with confidence 95% it could be Streptococcus pneumoniae, which are gram-positive, as you know, diplococci, and you can expect the antibiotics which could be useful against this microorganism. In case of a bronchopneumonia, it could be staph, could be strep, could be Haemophilus influenzae, so different microorganism. And therefore, you can tailor your antibiotic prescription accordingly. And lastly, the consolidation, look, diffuse involving the whole lobe. Usually. It is usually unilateral, right? And limited by the atomic boundaries of the lobe, as I said. While in bronchopneumonia, patchy around the bronchioles, usually bilateral and not limited by the boundaries of the lobes. So good differences, obvious differences between Lobar pneumonia and the bronchopneumonia. As we said, this is the gram-positive diplococci, which are capsulated. You can see the halo around them, capsule around Streptococcus pneumoniae, and they are diplococci, arranged horizontally, tip to tip like that. Other classifications are present other than what I have prescribed to you about the CAP, HAP, and immunocompromised. There is a classification according to the anatomical distribution. Lobar, which is usually bacterial. Bronchopneumonia, lobular, part of lobules. Patchy, bacterial again. Interstitial pneumonia, which appears radiologically as reticular pattern, زي الشبكة, reticular, right? And we will have examples. Mainly this type of pneumonia is seen in immunocompromised, for example, in HIV infection. According to the etiological agent, infectious, non-infectious. Infectious, which could be caused by microbial, bacterial, viral, fungal, tuberculosis. Non-infectious, chemicals, aspiration. There is a type of pneumonia called aspiration pneumonia, aspiration of vomitus. A patient unconscious or after anesthesia aspirate his vomitus. This is not due to microorganism, due to chemicals. According to the duration, pneumonia could be acute, could be chronic. Histologically, there are two words which are very important, and you may deal with them during the text. When you read textbook or a journal, called typical pneumonia and atypical pneumonia. Typical pneumonia, intraalveolar oxidative consolidation, which is bacteria. This is the usual one. Consolidation, alveolar, usually bacteria. Now the atypical, sometimes they tell you this is atypical pneumonia. What is the meaning of atypical? Mononuclear interstitial. I just mentioned the interstitial in immunocompromised, and including viral and mycoplasma. Mycoplasma pneumonia is a common cause of pneumonia, and the pneumonia which is caused by mycoplasma pneumonia is called walking pneumonia. يعني يجي المريض ده يمشي عندك. Let us start with the cap. How many caps we can get? They say between 5 and 11 per thousand. This is in UK. Of course, it could be other countries higher than this figure, for example, in the Middle East. And the incidence and mortality higher in very young and very old, and we said that. The spread usually by droplets. A patient with infection can spread the microorganism, and other individuals can get it. And we will see what are the predisposing factors for pneumonia in the next slide. Streptococcus pneumoniae is the most common agent in bacterial pneumonia, in Lobar pneumonia. We said 95%. ممكن واحد يسألني دكتور في فيرال؟ في فيرال. كاب فيرال. Community acquired pneumonia في فيرال. And this is important in children. And in the following table, the predisposing factor to pneumonia. يعني مين يصير عنده pneumonia؟ Smokers, person with upper respiratory tract infection. Common history هذا. واحد يصير عنده flu, upper respiratory tract infection, like bronchitis, ويقول لك بعد اسبوع والله الانفكشن نزل على صدره. شو معناتها؟ صار عنده pneumonia احتمال. Okay, this is common. If the patient is not treated well, if he didn't take enough rest or protection, and if his immunity is not that good, immunocompromised, the infection may spread downwards and get pneumonia. Alcoholic, corticosteroid therapy, of course corticosteroid. Why? Because it decreases the immunity. Old age group, the immunity of old age group called immunosenescence. What is immunosenescence? يعني شيخوخة جهاز المناعة. جهاز المناعة من يكبر بالعمر decrease in efficiency. Recent influenza infection مثل ما حكيت هلا. Predisposing lung disease، واحد عنده أسمة أكيد معرض للنيمونيا أكثر من غيره. HIV and indoor air pollution, crowdedness in residency. Shisha smoking can predispose the individual to pneumonia. One shisha session for 1 hour, according to WHO, equals smoking 100 cigarettes. Just for your information. صبايا وشباب. The organisms which are many bacterial causes and many viral causes. The most important four causes, Streptococcus pneumoniae, then Mycoplasma pneumonia, I just mentioned it, Legionella pneumophila, Legionella, and Chlamydia pneumoniae, and others, Haemophilus, Staph, Chlamydia, Coxiella, Klebsiella. Viruses, the main viruses, influenza and para-influenza. And usually you get classical influenza followed by pneumonia. Measles. Why measles? Measles suppress immunity. And herpes simplex and varicella and others also. The clinical features in acute illness, the patient will have both respiratory symptoms and general symptoms. The condition may start with fever, rigor and shivering. I have seen rigor and shivering, very important. The great majority of cases of pneumonia, acute pneumonia, of course, that I have seen, they complain of shivering. So if a patient comes to you with fever, respiratory symptoms, although mild, with shivering and rigor, you have to remember pneumonia. And then the patient will have vomiting. Vomiting predominates also in the beginning of the start of the sign and symptom. Loss of appetite, headache, also common. First of all, the symptom, the patient may have a breathlessness and a dry cough. مرات الأطباء يسأل يقول له الكف تبعك في سبيوتم، يقول له لا، يقول له dry cough. يتصور this is a bronchitis. It could be pneumonia. The cough in pneumonia start to be dry. Later on, the sputum become mucopurulent, right? And sometimes the color of the sputum can give you a clue about the causative microorganism. Rusty sputum, rusty بمعنى بلون الصدأ, not a bleeding. بلون الصدأ may indicate Streptococcus pneumoniae. Sometimes you get hemoptysis associated with pneumonia. A pleuritic chest pain, we said parapneumonic effusion, pleurisy. So the patient will have pain during the breathing and cannot cough because of the pain. So during the treatment, you have to stop the pain in order to enable the patient to cough. Otherwise, the sputum will stay in the chest and cause obstruction and more inflammation. Sometimes the patient gets upper right abdominal pain, especially when the patient have got lower pneumonia associated with hepatitis. So lower lobe pneumonia and hepatitis may cause upper abdominal tenderness, mainly at the right side. Now, when we say consolidation, consolidation is a proteinaceous fluid. Fluid protein عالي with inflammatory cells congested in the alveoli, leading to consolidation. هذا الفلويد من يبقى فترة بالالفيولاي، لو فرضنا هاي الالفيولاس هون يبقى الفلويد فترة هون، it will consolidate, it becomes solid mass-like. So this is called consolidation. The consolidation passes into, first of all, into red phase and then a gray hepatization. Why hepatization? The color of the liver gray in color, okay? So now if you get a mass, suppose this is the bronchus, and then you get a mass here, right? Or like that, put it like that. Now, the mass, this mass, when you put your stethoscope over the area of consolidation, you are going to hear what? Bronchial breathing. لأنه هذه الماس هي ناقلة للصوت. تمام؟ هذه الماس الكونسوليديشن راح تنقل الصوت من البرونكس للستيثوسكوب تبعك وتسمع برونكيال بريثينج. فإذا البرونكيال بريثينج generally speaking it could be due to consolidation as in pneumonia. It could be due to what? Could be due to mass like a tumor. تمام؟ Crackles are also can be heard in the area of consolidation. Investigation, first of all, don't jump to diagnosis and you say this is pneumonia. There are other conditions, and I am going to enumerate them to you in the next slide, which can mimic, can be similar to pneumonia. So don't jump immediately and say this is pneumonia. Just you think about your diagnosis, exclude other causes, and then say this is pneumonia. So there are other conditions that mimic. The second thing to assess the severity, because severe pneumonia treatment is different from uncomplicated pneumonia. Different approach. So you have to assess the severity. And the third point, you have to identify complications. And I'm going to mention to you in a moment what are the complications that could result from pneumonia in order to treat them. So first of all, you can take chest X-ray, which can confirm your diagnosis. You have heard that there is bronchial breathing, and by percussion the area is dull. So you are suspecting pneumonia, and the history of the patient, the signs and symptoms that I have just mentioned. You say pneumonia, just confirm it by chest X-ray. In Lobar pneumonia, we'll see homogeneous opacity that will start very rapidly. In 12 hours to 18 hours, you get shadowing. And it will stay. Even after the patient is improved and cured, the shadowing will stay maybe up to 6 weeks. So if you discharge a patient from the hospital, don't take X-ray again, because shadowing will be present. It starts very rapidly. Within half a day, you get shadowing by chest X-ray, and maybe associated with effusion, abscess formation, empyema. Empyema is a plural effusion, but the fluid becomes pus. So it is pus in the pleural cavity. You can do also microbiological tests to identify the microorganism. Legionella pneumophila is notifiable disease. You have to tell the health authorities that we have isolated Legionella pneumophila, because this microorganism can come in hostels, in hotels, in colleges, in schools, mainly hotels, due to the air conditioning system, cooling system. All right? So this microorganism can be transmitted or through the water reservoirs, tanks, خزانات المي. فاحنا من نروح على المستشفى بهيك حالات وعندنا pneumophila suspected, you have to check the water storage tanks. Also microbiological testing to identify the microorganism and also to guide the antibiotics. The microorganism to which antibiotic is sensitive. Although we can expect, when you expect the microorganism, you can expect the type of antibiotic according to the best guess of the doctor, but also it can give you exact antibiotic that will be beneficial to the patient. Differential diagnosis of pneumonia. I said there are some conditions which can mimic, can be similar, like what? Pulmonary infarction, pulmonary pleural TB, tuberculosis, pulmonary edema. Pulmonary edema could be unilateral, not always bilateral. Pulmonary eosinophilia, malignancy, carcinoma could mimic pneumonia with the bronchial breathing and other things. And also rare disorders, a cryptogenic organizing pneumonia, bronchiolitis, obliterans. These are fibrosis-based diseases. There is fibrosis, okay, which can also mimic pneumonia. How to continue with the investigation? The simple test is to measure arterial oxygen saturation. You put the pulse meter on the finger and you find the oxygen saturation. Important, you have to use oxygen therapy if the oxygen saturation is less than 93%. كونستانتي. طبعا هذا يتغير البلس ميتر الاوكسيميتر يتغير، يعني تشوفه انتم شايفيه في المستشفيات صح؟ مره يقرا 94 مره يقرا 90 مره 92. But you have to take the predominant reading and pick up the percentage of the saturation, and if it is less than 93%, the patient requires oxygen. And also if the patient shows severe pneumonia, and I am going to give you what are the parameters by which we can categorize the pneumonia as severe. So these cases, severe pneumonia, you should give them oxygen. White BC, it could be normal. It depends on the microorganism. In neutrophils, more than 15 may indicate bacterial causes. Too low, less than 4. Too high, more than 20, may indicate severe pneumonia. Right? CRP and ESR will be elevated. These are inflammatory markers. You have to check urea, electrolytes, and liver function as a baseline, because the patient have systemic manifestation, so of course the kidney may be affected. And assess the disease activity, how we can assess the severity of pneumonia. There is a formula called CARE 65 scoring system. This system, we can see this X-ray, there is shadowing here, right? This area is below the horizontal line, as you know, as you can see, and this could be middle lobe pneumonia or lower lobe pneumonia. We are on the right side, okay, 3 lobes. How we can know that this is middle lobe or lower lobe? We take lateral view. If the consolidation is towards the sternum, this is the sternum, this is middle lobe. If it is towards the vertebral column backwards, it is lower lobe pneumonia. So what do you think this one? Middle lobe pneumonia. تمام؟ ترى هذا السؤال كان أحد الأسئلة بالأوسكي، بالميني أوسكي، ها، في أحد الميني أوسكيات السابقة لعلمكم يعني مو دا أقول لكم يعني بس حتى تعلموا كيف تجي الأسئلة يعني. خليت هاي صورة وسألت هذا ميدل لوب لور لوب. كيف تقول ميدل لوب؟ anterior position. The formula which I said is curve 65. C is confusion. U is urea more than 7 millimole per liter. Respiratory rate more than 30 per minute. Blood pressure systolic less than 90, or not and, or diastolic less than 60 millimeter mercury. Right? Age above 65, that is why it is called curve 65. 65 is the age of the patient. For each point, you get one score. So a patient who has got 0 or 1 score can be treated at home. 2 points, 2 scores, you can consider hospital supervised treatment. Either you keep the patient short stay inpatient, تدخلوا في كم ساعة هيك وتطلعوا، أو outpatient supervised treatment, outpatient clinic. بقي كم ساعة تأكد منه أموره كويسة، you can discharge him. 3 or more, you have to admit the patient to the hospital. If the patient scores 4 or 5 from those admitted, should be treated in intensive care unit. Clear? 3 فما فوق ندخلوا مستشفى. من دول الداخلين بالمستشفى إذا السكور تبعه 4 أو 5 you put him in the intensive care unit. How to investigate the CAP? احنا لحد الآن بدنا نحكي على الكاب، community acquired pneumonia. There are different parameters that we have to check. You can read them, all of them. But I have marked with arrows the investigations which may indicate severe pneumonia. White BC, very high, above 20, less than 4, indicates severe pneumonia, and I mentioned this point. Another point, urea, when it is more than 7, it indicates millimole per liter, it indicates severe pneumonia. Hyponatremia, common in pneumonia. Low sodium is common in pneumonia, especially severe pneumonia. About 25% of the cases of pneumonia associated with hyponatremia. In particular, the severe pneumonia. Liver function test, when you get hypoalbuminemia, low albumin in the blood, this is another marker for severity. Bacteremia, presence of bacteria in the blood, indicates pneumonia. Now there are other investigations. One of the investigations that I would like to draw your attention to it, patient with mycoplasma and chlamydia and legionella and viral infection, you may get antibodies against these microorganisms. But after a while, not immediately. Cold agglutinin, for example, found in 50% of patients with mycoplasma pneumoniae. شو هو الكولد اجلوتينين؟ antibodies IgM precipitate at 4 degrees centigrade. اسمه كولد اجلوتينين. شو معناته كولد اجلوتينين؟ يعني يشتغل في درجات البرودة. كولد اجلوتينين. اوكي؟ ممكن واحد يسألني دكتور ودرجة حرارة الإنسان 37 شو يعني كولد اجلوتينين وين يشتغل بجسم الإنسان؟ مين يجاوب؟ ترى البلد سيركوليشن تروح إلى الفيت. في بعض السيتويشن الإنسان قد يكون موجود في environment which is very cold, all right? And the blood circulation, when it goes to the periphery, it may reach to degrees which are much lower than 37 degrees centigrade. And then when it retains back the blood, it becomes warmer and warmer, and so on. So it can act. Other investigations, sputum, gram stain, and culture, PCR, urine, look, pneumococcal antigen or Legionella antigen in the urine. This is a common question. What is the best diagnosis, the best test that can be done for Legionella pneumophila diagnosis? And they put to you different, one of them practical and useful, Legionella antigen in the urine. Okay? Of course, imaging, Lobar pneumonia حكينا عليها, bronchopneumonia, complication حكينا, Staphylococcus aureus حكيت لكم سابقا, pyogenic microorganism. شو معناته pyogenic؟ تعمل pus. فإذا أنت صار عندك patient عنده ستاف أوريوس نيمونيا, ايش تتوقع؟ يصير مكانات بيها pus. الباس هذا will be discharged, شو يبقى مكانه؟ cavity. فيصير عندك cavitation. إذا شفت cavitation, it could be Staph aureus pneumonia. Of course, you can aspirate the pleural fluid. You do microbiological tests on it, gram stain, culture, etc. Indication for referral to intensive care unit, we said care 4 or 5. Okay. Secondly, persisting hypoxia. When the partial arterial oxygen tension هذا, شوفوا مو blood saturation, arterial saturation, هذا partial oxygen tension less than 8 kilopascal, which is less than 60 millimeter mercury, despite high oxygen. Normal PaO2 between 10.6 and 13.3 kilopascal. That is to say, 80 to 100 millimeter mercury. So if the patient is persistently having hypoxia, you have to admit him to the intensive care unit. Progressive hypercapnia, المريض يتنفس بسرعة. Severe acidosis, circulatory shock, and reduced consciousness. All these patients should be admitted to the intensive care unit. We said pneumonia have complications. حكينا انه we have to assess the oxygen saturation, تمام, and we have to assess the complications, and you have to assess the severity of pneumonia. Now the complication parapneumonic effusion, empyema, retention of sputum, which can block the certain areas of the lung parenchyma and produce consolidation. Deep venous thrombosis, pulmonary embolism, pneumothorax, particularly with staph aureus. ليه staph aureus؟ تعمل رابتشر من الكافيتي على البلورا، يصير عندك نيموثوراكس. تمام؟ acute respiratory distress syndrome, renal failure, multi-organ failure, ectopic abscesses. بيحل الectopic abscesses staph aureus. Hepatitis, pericarditis, myocarditis, meningoencephalitis, pyrexia, etc. These are complications. How to manage? First of all, you have to pay a lot of attention to the oxygenation of the patient. Secondly, fluid balance. Thirdly, antibiotic therapy. أربعة, nutritional support. In severe and prolonged cases, who stays long time in the hospital. So the priority, not the antibiotic. Priority, oxygen. And the fluid balance. Oxygen, you give oxygen to all patients with tachypnea, hypoxia, hypotension, or acidosis. You have to maintain the oxygen, partial oxygen saturation 8 or above kilopascal. That is to say, more than 60. And the oxygen saturation اللي أخذناه بالأوكسيميتر 92 and more. لعلمكم هيك يعني، بس أعطيكم معلومة، قد يجوكم تقارير أحيانا. الخطوط الجوية تبعث مرات ريبورت إلى المستشفى هل هذا المريض يستطيع السفر بالطائرة؟ إذا الأكسجين saturation 92 or below cannot travel by aircraft. 92 أو أقل. فإحنا 93 مقبول، يقدر يسافر. تمام؟ فأنت من يصير 92 you have to give oxygen. Non-invasive بهيك حالات non-invasive ventilation through the mask or tubes limited. Better, theoretically speaking, is to use mechanical respirator. أجهزة التنفس الاصطناعي. أنا أعتقد يعني رأي شخصي هذا، لا تأخذوا به، بس أنا بانطباعي من خلال الممارسة الطبية الطويلة أنه الميكانيكال ريسبيريتور more difficult and more complications. يعني بيجيب لنا مشاكل أخرى غير اللي احنا دا نعالجها. A fluid balance you give intravenous in severe cases, older patient with vomiting. We said vomiting predominates, so you have to correct the balance. The other point, if the patient has got circulatory shock or failure, you have to give inotropic support. You know the meaning of inotropic, yes? Antibiotics, prompt administration of antibiotic. This is the cornerstone, but not the priority. Priority is the oxygen, we said, and the fluid balance. And antibiotic can be selected to different bases. The severity, the clinical severity, and antibiotic policy. Each hospital or each country, you can say, has got antibiotic policy. يعني أنت إذا تعالج مريض في بريطانيا مثلا مو بكيفك، مو حسب أنت رأيك، في guidelines uncomplicated الantibiotics. complicated في antibiotic, severe cases في antibiotic. والسيفير cases categorize أيضا حسب ما حكينا. فإذا في guidelines for treatment. So we select antibiotic according to the clinical status of the patient, severity, and the local antibiotic therapy. Mycoplasma pneumonia or pneumonia, it's sensitive microorganism. 7 to 10 days of treatment will be enough. It's called walking pneumonia, as we said. Legionella, Staph, Klebsiella require longer treatment, of course, and we will see that in a moment. Oral antibiotic is or are the preferable route, is the preferable route of administration of the antibiotics. Parenteral, intravenous or intramuscular, mainly intravenous, can be used for severe cases, number one, and in complicated cases, or the patient is unconscious. In this way, of course, you are obliged to use intravenous. The treatment of a pleural pain, you know the pain, it prevents the patient from breathing normally, first of all, and secondly, it prevents the patient from expectorating the sputum. And if the patient cannot expectorate the sputum will stay in the bronchi, in the bronchioles, and will be inspissated, تتيبس, and can cause more consolidation and more blockage to the lung parenchyma. So you can use simple analgesia, paracetamol, cocodamol, or NSAIDs. Opiate, you have to be careful in using opiates. Why? Because they can cause respiratory failure, inhibition of respiration. Physiotherapy, important. It can assist in expectoration. The patient will get rid of the inspissated sputum inside his bronchial tree, right? So physiotherapy is important, and they are very skillful physiotherapists. عندهم طرق يخلي المريض discharge the inspissated sputum in the bronchial trees. Prognosis, most patients respond to antibiotic. Fever may persist for several days, so don't worry. Fever can stay. Remember, we are dealing with consolidation. Consolidation مو يوم وثاني يوم تختفي. Takes a while until it will disappear. And the chest X-ray, don't repeat the chest X-rays. يعني فد خطأ شائع أسبوع ويعيد للإكس-راي، أسبوعين ويعيد للإكس-راي. Misleading. حكينا shadowing يبقى it stays up to 6 weeks. A question, common question. Do you take chest X-ray when the patient is discharged? No, of course not. If you take the chest X-ray, the consolidation and shadowing is still present. If you get delay in the recovery, يعني احنا حكينا اسبوع المريض يصير اوكي مفروض يعني. اذا صار عندك delay شو معناته؟ complication. Diagnosis incorrect. ليه diagnosis incorrect؟ حكينا many conditions mimic similar to pneumonia, you have to reconsider your diagnosis, or you get obstructive or aspiration pneumonia اللي حكينا عليه قبل شوي. Mortality in adult less than 1%. In hospitalized patient with pneumonia, higher mortality. 5 to 10% of them will die. 50% of them in severe cases. 50% of the deaths among the hospitalized are the pneumonia which are marked as severe pneumonia. The antibiotics that are used in CAPS can be divided according to the condition, the clinical status of the patient, into uncomplicated CAP and severe CAP. Uncomplicated CAP, let's شوفوا الجدول الطويل. Very simple. Amoxicillin 500 milligram orally 3 times daily. Okay? سهلة بسيطة، خاصة those patients who are treated at home. amoxicillin. وليه amoxicillin؟ كان اختارنا فد اشي شوي اضبط. ستريبتوكوكس نيمونيا 95% عندك نجاح لقدام. Which are sensitive to amoxicillin in general. If the patient is allergic to penicillin, clarithromycin will be the alternative. 500 milligram twice daily. شو بديل الكلاريثرومايسين؟ الاريثرومايسين العادي يعني اللي ناخذ 4 مرات طبعا. هذا لونج اكتنج هذا الكلاريثرومايسين. If you suspect special staph aureus, you have to use flucloxacillin, okay, intravenously plus clarithromycin intravenously. سابقا كان حكينا اورالي، اريدكم تهتمون بالاورال والانترافينوس، ترى common questions especially in MCQ international examination مو يرموك university examination بيسألوا انترافينوس لو اورال. اوكي، فاذا combination of intravenous اذا استاذ هي دائما حكينا بالاندوكاردايتس، حكينا راح نحكي بغير مكانات. دائما we are fearful from staph aureus, very resistant and produce beta lactamases, penicillinases enzyme which can break down the antibiotics. If the patient has got mycoplasma or legionella, clarithromycin orally or intravenously plus rifampicin also intravenously twice daily. طبعا من تقول انت كلاريثرومايسين، الالترناتيف هو اريثرومايسين. نحن ممكن بين شويه نعيدها. In severe pneumonia you always use intravenous. من حكى لك severe pneumonia ما في مجال oral. Okay, so you can use clarithromycin intravenously plus عندك عدة خيارات. right, clarithromycin intravenously plus what? plus co-amoxiclav intravenously. شو هو الكو أموكسيكلاف؟ فإذا كو أموكسيكلاف بلس or cefitriaxone third generation cephalosporin or cefuroxime intravenous also or amoxicillin plus flucloxacillin. واضح؟ يعني بالبداية كلاريثرومايسين بلس co-amoxiclav or ceftriaxone or cefuroxime كلها intravenously or combination of ampicillin and flucloxacillin. ليه combination of flucloxacillin؟ لأن هذا الفلوكلوكساسيلين resistant to destruction by beta lactamases. دي فلوروبيكلور فلوكلور. شو فلوكلور؟ فلور وكلور. right؟ هذا فلو شارت أيضا يحكي على نفس التيبل الموجود. patient عندك clinically suspected to have pneumonia. تعمل sputum examination gram stain. Counter current immunocompromised. Counter current immunocompromised, you put your sample here and you put antibody against it. If they meet by current خلال ساعة زمن بسرعة يطلع precipitation line. هذا شو اسمه counter current immunocompromised. You drive the antigen towards the antibody and the antibody towards the antigen and they get a precipitation. And also you can do blood culture and sputum culture and you can do also serological test اللي حكينا عليها called hemagglutinin مثلا. Legionella pneumophila in the urine and so forth. Mild community acquired, we said amoxicillin orally or clarithromycin, and the patient will respond within 48 hours. If no response, you have to check the X-ray and review the treatment of the patient. Severe community-acquired pneumonia approved by chest X-rays, diffuse or localized. You can use intravenously cefuroxime plus clarithromycin. نفس الكلام حكينا clarithromycin plus intravenously وعديتهم الانتيبيوتكس اللي ممكن ياخذ المريض. If the patient has no staph aureus, review the clinical picture and you transfer the patient to oral antibiotics. If you suspect staph aureus by culture or you can see gram-positive cocci, then you add flucloxacillin. ليه flucloxacillin؟ لأنه resistant destruction. Sometimes they use fusidic acid, 500 milligram, and then adjust the antibiotic according to the clinical picture of the patient. Discharge and follow-up. literature غربية يقول لك تعتمد على الهوم كونديشن اوف ذا بيشنت. قسم منهم يعيش لحاله، رجال كبير مرأة كبيرة. So it depends on the home of the patient, whether they have got heating system or not, or something like that. So this will be left to the social workers. You don't need to repeat the chest X-ray. It takes 6 weeks to resolve, at least. Prevention, patients should stop smoking, of course. We said smoking #1 predisposing factor. Some patients who are susceptible to get repeated pneumonia get immunized against influenza or pneumococci. Also immunization against pertussis and Haemophilus influenzae. And Legionella pneumophila, as I said, notifiable condition. HAP. What is HAP? Hospital-acquired pneumonia. We finished with CAP. Now we talk about CAP for a short while. Who are the patient who gets HAP? The patient who gets 2 days after admission pneumonia. After admission, or have 2 days or more admission in the last 90 days. هذه هي الهاب. Now, it is a leading cause of death among the hospital acquired infection. تعرفوا موضوع فيه اسمه hospital acquired infection اللي نسميها أحيانا nosocomial infection. Pneumonia is a leading cause of death among these diseases. Older people who are at risk, especially who are on mechanical respiration. حكيت mechanical respiration ترى في complication. What are the etiology? If the patient gets the sign and symptom within 4 to 5 days of his admission, usually similar to CAP اللي حكيناه. If it is more than a week, it will be mainly gram-negative bacteria, gram-negative bacilli, like E. coli, Pseudomonas, Klebsiella, or sometimes you can get Staph aureus MRSA or anaerobe. Staph aureus common in hospitals. يعني أنت من تدخل مريض إلى المستشفى، القاعدة الأساسية، شو هي القاعدة الأساسية؟ أن يبقى المريض أقل ما يمكن من فترة بقاء بالمستشفى. Why? Because of the nosocomial infection, especially with microorganisms which are very resistant to many antibiotics. The factors that predispose the patient to develop HAP: reduced host defenses, reduced immunity, patient taking corticosteroids, cytotoxic drugs, reduced cough after anesthesia, for example, and so on. Disorder of mucociliary after anesthesia, reduced cough after operation, in neurological conditions, aspiration, immobility, vomiting, nasogastric intubation, bacteria which are introduced to lower respiratory tract, for example, endotracheal intubation, tracheostomy. All these can introduce bacteria to the lower respiratory tract. Patient on ventilator, bacteremia, intravenous cannula, and so on. Clinical pictures of HAP. You have to consider HAP if the patient will develop purulent sputum. ما كان عنده purulent sputum. الآن صار عنده purulent sputum. New radiological shadowing or infiltrate, temperature more than 38.3 degrees centigrade, leukocytosis or leukopenia. Biomarkers and microbiological study, there is a way which is called bronchoalveolar lavage. شو bronchoalveolar lavage? You push buffer like saline, sterile of course, to the respiratory tract, and there is apparatus which aspirates as if you are washing the respiratory tract, and you get sample which will be used for microbiological study or culture. All right? It's called bronchoalveolar lavage. Or you can use endotracheal aspirate. You put a tube inside the trachea and you aspirate, which is less reliable than BAL. Less reliable. Management, you can use your judgment. If it is within the first 3-4 days, we say similar to CAP. So the treatment can be applied of the CAP. If it is longer than that, a week or so, you can use antibiotics which are mainly against gram-negative bacilli, like E. coli, like Pseudomonas, like Klebsiella, etc. So against gram-negative bacilli. Example, third generation cephalosporin, cefotaxime with aminoglycoside. As I said last time, there is synergism between aminoglycosides and cephalosporins, or meropenem, or azithrionam with the flucloxacillin. Azithrionam against gram-negative, okay? Narrow spectrum antibiotic. MRSA, vancomycin. You add vancomycin. You can use also other antibiotics like doxycycline, rifampicin, linezolid. It depends on the situation. Most of the hospital-acquired pneumonia patient requires intravenous antibiotics. Physiotherapy is important. Adequate oxygen. Restore fluid electrolyte balance. Now the last type of pneumonia, we said 3 types: CAP, HAP, and pneumonia in immunocompromised. We said interstitial pneumonia. Immunocompromised, I see immunocompromised. Patients who are immunocompromised by using certain drugs like cytotoxic drugs, or patients who are HIV infected. It is caused by unusual microorganisms which are usually not causing diseases in immunocompetent individuals. Example, gram-negative Pseudomonas aeruginosa. Pseudomonas aeruginosa, it can cause immunocompetent or immunocompromised. Very powerful microorganism. Viruses, fungi, mycobacteria, nocardia for example. انت ما تشوف نوكارديا infection من اي تشيو سواء باللنك ولا بغير اللنك بالبرين مثلا. The patient is usually immunocompromised. خلوها في بالكم. النوكارديا مع الاميونوكومبرومايز ستاتس. جرام بوزيتيف فيلامنتس هتشوفوها زي الخيوط. These patients who are immunocompromised may get more than one microorganism. Why? Because their immunity is low. Patients suffer from fever, cough, breathlessness, معروف. عندنا فت فنجس اسمه نيموسيستس كاريني، واسمه الحديث نيموسيستس يوروفاكاي، ولا زال لحد الآن تسمى Pneumocystis pneumonia. This microorganism, common infection among HIV or AIDS patients. It's slowly, not rapidly, less rapid, opportunistic organism. The patient will suffer from cough, breathlessness before radiological abnormality. So you get scenario, a patient who has normal chest X-ray, breathlessness, cough, كذا. He's taking cytotoxic drug for malignancy treatment. He has got the pulmonary symptoms, most probably due to 1, 2, 3, 4. Pneumocystis eurovaccae. Okay? Less rapid. The infection starts before the radiological appearance. Sometimes you get invasive pulmonary aspergillosis. الاسبرجيلا موجود بالانفايرومنت بكثرة. اوكي؟ فيخش واحد immunocompromised عنده cavity. The aspergillus will go and sit in the cavity. Diagnosis: invasive bronchoscopy, bronchoalveolar lavage, transbronchial biopsy are not practical. High resolution CT scan. HRCT شو معناتها؟ High resolution CT scan is useful. Management: third generation cephalosporins or quinolones, plus anti-staph antibiotic. مين يعطيني anti-staph antibiotic؟ Okay. So anti-staph antibiotic, anti-pseudomonal, penicillins with aminoglycoside. Anti-pseudomonas من يعطيني؟ بعد piperacillin, mezlocillin, azlocillin. Okay? Antifungal, antiviral, it depends on the situation. Non-invasive ventilation via hood is effective. The last category that we are going to talk about it is suppurative pneumonia or aspiration pneumonia and pulmonary abscess. Aspiration pneumonia very important. Many patients يطلع من العملية يستنشق الفوميتاس. Suppurative pneumonia, there is destruction of the lung and you get microabscess formation. المicroabscess formation إلها عدة تفسيرات. احنا we don't jump راسنا نقول هذه aspiration pneumonia. فإذا pulmonary abscess, cavity or collection of pus, developed usually after inhalation of septic material. The microorganism also can be aspirated with the vomitus, with the chemical destruction. There are microbes also, aerobes and anaerobes. These microorganisms, bacteroids, fusobacterium, these are anaerobic. Bacteroids and fusobacterium are anaerobic microorganisms. Some cocci, Staph aureus, Klebsiella pneumonia, suppurative, pus-forming. You may get community-acquired MRSA, CA MRSA. This is a new category. So you get pulmonary infarct, collapse, and intravenous drug abusers common. Remember, there is a condition called ليمير syndrome. شو هو الليمير syndrome؟ هذا هو ليمير، عالم فرنسي. ليمير syndrome in which there is pulmonary abscesses، يعني مو aspiration pneumonia، تختلف. أنا حكيت أنه مو إحنا من نشوف لنا مايكرو abscess نقول نيمونيا، لا، في ليمير syndrome as differential وراح نحكي عليه بعد شوي. Radiologically homogeneous lobar segmental abscess formation, abscess characterized by cavity and the fluid level. Sputum and blood culture can be done. This is the fusobacterium most common of Limier, gram-negative rods. Fusobacterium anaerobic. شو هذا الليمير؟ Limier, if the patient gets abscess around the tonsil, peritonsillar area, and this pus formation or abscess get entrance to the superior vena cava, to the subclavian vein, and then to the superior vena cava. This will spread to the lung and cause microabscesses, mainly caused by fusobacterium. So you have to, we said aerobic and anaerobic. So when you use treatment, you have to cover anaerobic. The best drug which can be used for anaerobic is what? Cotrimoxazole. Flagyl, metronidazole. Metronidazole. Okay, so you can use metronidazole 400 milligram. And how you know that the patient has got anaerobic infection? It is fetor odor sputum، يعني رائحة كريهة بالسبيوتم. هذا شيء يدلك على anaerobic microbes. Community acquired MRSA, cotrimoxazole, clindamycin, tetracycline, linezolid, parenteral intravenous vancomycin and daptomycin, fusobacterium, beta-lactam, metronidazole, third generation cephalosporin. GS هذه شو هي؟ third generation cephalosporin for 4 to 6 weeks, long time, because resistant of microorganism and due to the formation of lung abscesses. Physiotherapy also important, and surgery may be required to evacuate the pus from the lung if medical treatment is not enough. Lastly, I will leave you with 3 videos. These videos are very interesting, similar to what I have discussed to you, but you will see more pictures and more images. Any question? Clear? Okay. Allah يعافيك.
دكتور الابس دكتور ولا مين؟ يعطيك العافيه دكتور.
الله يعافيك.
دكتور الابسس ممكن حالة بدون ما يكون في بدون ما
سيرجري؟
بدون اسبيريشن.
ممكن. لان ابس هاي مايكرو ابس. هاي مو ابس.